Hi, I'm Dr. Minerva Santos, and welcome to Your Health Today. My guest today is my good friend and cardiologist, my cardiologist too, Dr. Binoy Singh, and cardiologist for my husband, who gives him a lot of trouble, and my brother. Welcome.
Thank you. Thank you, Dr. Santos.
There's a lot of things that we can talk about in reference to cardiology, and I think the most important thing is talking about what's new in cardiology. Everybody hears about cholesterol, everybody knows about caths, but what's new and what's cutting edge? What's happening in cardiology today?
Well, Dr. Santos, thank you for the opportunity to be here today. There are many things that are exciting and new in cardiology. I think that if we take the entire field and we kind of have to break it down into a lot of
5 shows.
Exactly. To really be, I think, comprehensive about reviewing all the new things and the new developments within the field. But I think probably just based in the context of what's happening in healthcare today and how we want to be able to identify folks who might have cardiovascular disease very early in the disease process so you can prevent things like heart attacks and strokes and even early demise, it really becomes important to maybe focus on what are the tools or new techniques that we're going to identify folks with who have disease. So, traditionally, what we've done is essentially ask patients, how old they are, whether they have symptoms, if you're over the age of 40 or 50, if you're 40 a male or 50 a female, your risk for cardiovascular disease, and in particular, atherosclerosis goes up. And then we ask them how they feel. Are they having chest pain? Are they having shortness of breath? These are pretty typical symptoms that most folks might experience. Although what's interesting is that probably 30 to 50% of patients may have no symptoms whatsoever when they have cardiovascular disease, or some very atypical symptoms like fatigue.
Right, especially women.
Exactly.
Fatigue gets very confused with menopause symptoms too, because of fatigue, extreme tiredness are all symptoms that women who are menopausal really need to look out for.
Absolutely. Palpitations even, which are oftentimes blown off as
menopause
or anxiety, when in actuality they may be early warning signs of atherosclerotic disease. So as we go through this initial evaluation with patients, we try to identify or assess their risk for disease. And then oftentimes folks are referred for stress testing. If they have one or
That's
more
what I
of these
do all the time.
one or more risk factors, and these stress testing techniques vary in terms of style, vary in terms of technique, and then also, how accurate are they? We often hear the story of someone who's recently had a stress test, told it was completely normal, and then they go on to have, within a short period of time, either symptoms that would suggest that they really have significant disease where the stress test didn't pick it up, or they go on to have an event like a heart attack, and now you're dealing with a significant consequence of the disease state. So what we are doing now is trying to really use some of these tools in the traditional delivery of care and recognizing those who have cardiovascular disease, but trying to enhance either their accuracy, the tools that we're currently using, or look at newer techniques that might be out there to help better define disease. So, I think when it comes to stress testing, I think a lot of folks think, well, what test do I get? Somebody tells me I should get a stress echo or a stress nuclear study, or should I just get a treadmill test with an electrocardiogram only? And I think that where the practice is going is that we know that stress testing with some form of imaging of the heart muscle, whether it's nuclear imaging or whether it's ultrasound imaging or whether it might even be MRI imaging through stress testing techniques, these are the standard tools, and iterations of advancements in the technology help potentially enhance the accuracy of those tools to identify who's at risk and who might have disease. So, ultrasound technology is something that we use often in our assessment of patients, and it's a real effective tool without having radiation exposure. It's a shorter test. It's real-time acquisition of myocardial function as a marker for who might have cardiovascular disease. So we've used that tool effectively for almost 3, maybe even a little more than 3 decades, nuclear stress testing has been a mainstay of how practices and patients have been able to identify folks with disease. But what's interesting is that oftentimes what we're using these tests for is to detect those who have significant disease.
Right, right.
And there's a limitation in that, because all our treatment strategies then are focused on, yes, we're preventing your heart attack, but we've already seen that you have, an 80% plaque in a blood vessel that didn't cause a heart attack but may be causing symptoms or identified on a stress test. Can we use tools that might detect disease even earlier in patients and then use some of the treatment strategies that are out there in those patients more effectively to prevent future stress testing needs, to prevent the onset or progression of plaque, and ultimately the consequences of plaque like heart attack or stroke? So there are some technologies that are out there, and interestingly, some of these are applications of old tools. So we can take ultrasound, for example, and assess the carotid arteries, the arteries in the neck. And what we do with this technique is essentially recognize that plaque is not a disease state that takes a tube, which is our artery, and essentially blocks the tube right away. It's a disease state that actually affects the wall of that tube first. And as it affects the wall of the tube wall thickens. And if you can detect very early on that there's thickening within a wall of an artery within the body, it's a clear marker that plaque is present, and that's what's causing this thickening. And then you can be much more aggressive about explaining to folks who have this thickening, much better for you to have tighter blood pressure control.
Right.
That you cannot settle for a cholesterol level that is at such and such level, or you have to say that tighter sugar control in those who have diabetes may be helpful in those patients from that plaque progressing and causing problems down
And
the
no
road.
smoking.
And no smoking, exactly, absolutely. And then, of course, other lifestyle modifiers like exercise. What kind of routine exercise should they be doing? And just this simple tool, ultrasound of the arteries of the neck, by detecting this thickness, and it's called intimal medial thickness, basically a thickness of the wall of the artery, you can use it as a marker for whether disease is present. And it's not new technology, it's application of old technology, but looking for disease in a different way. I think that there are even a number of other tools that are actually exciting applications of technology. One in particular, and the colleagues of mine who I have worked with in the past who have been essentially instrumental in understanding the value of the technology and what role it might play in patients. It is not necessarily, it's available in some practices where people are using this technology, but it's essentially a unique application of something you and I always do in our offices, and that is an electrocardiogram. So an electrocardiogram is basically a test that many in your audience, I'm sure, have had in their evaluations at their doctor's offices. It's essentially a picture. It's a picture of the electrical signal that the heart has to get for it to do its mechanical work of contracting and relaxing. And that picture is on a piece of paper, and we see it as a bunch of squiggly lines. Well, it's a reflection of how much voltage is generated to tell the heart, this is your time to contract or this is your time to relax. And this is a signal that is recorded over a certain fixed amount of time. So it's a real-time signal of an electrical event. And what's interesting is that there are so many mathematical, if you will, properties that go into making that signal, and we just see it as a bunch of squiggly lines on this paper, that when you actually take these very sophisticated mathematical techniques and sort of break down that signal into its most simplest components, some of which are frequency-based components, you can actually start to recognize patterns that may not be present or easily identified on the piece of paper that you and I use in our office. So this technology, which is essentially the breakdown of an electrical signal into its sort of intrinsic components, now becomes a tool that has been effective at identifying some very important, if you will, patterns, and then those patterns get associated with certain disease states. And there's a growing body of data, and this is called the MCG technology. And essentially, what it does is it recognizes that there are multiple components in this cardiogram assessment. And by recognizing and having a lot of data and if you will, a set of patients, thousands and thousands of patients, you start to recognize that certain patterns with these mathematical properties reflect coronary disease, somebody who is at highest risk, or somebody who might have the earliest signs of coronary artery disease. And now you can then properly triage them without ever having done a nuclear stress test or an echo stress test. And this is a simple screening tool that is done. And frankly, you know, the folks who are proponents of the technology and are clearly looking to make it much more mainstream for our patients are working with federal officials about how to recognize this as a technology that might be meaningful. So again, not mainstream, but yet very cutting edge, very, and I would say, accurate in its earliest data sets that have been published with peer-reviewed articles where you see that this technology has application. So MCG techniques, whether it's carotid duplex scanning or other manifestations in terms of iterations of how ultrasound machines are able to acquire images, what can we do to better enhance nuclear cardiovascular imaging. These are just some of the tools that are helping us advance how we detect disease in earlier stages or in more accurate ways. And what also comes to mind is, you know, in many men and women, the earliest manifestations of disease, when you see this thickening of the wall, one of the properties of the arteries, whether it's the heart arteries or blood vessels in the arm or in the neck or to any other vital organ, the property that gets altered once that plaque starts to destroy the normal architecture of the wall is the property of dilation. So our arteries are not lead pipes.
Right.
They're dynamic structures. And so the dynamic structures have the ability to dilate when the organ, the heart in particular, may want to get more blood. So the artery has to dilate and offer more blood. That's a normal response. But when plaque is present, and many people have done some very sophisticated studies where, you know, you take a meal like from Burger King or McDonald's, extraordinary fat content, you inhale this meal, okay, and then you can actually, people have studied how reactive the blood vessels are.
Oh, that's interesting.
Okay, and it's interesting that fatty food intake will actually alter the ability for the artery to naturally dilate. And it doesn't have to be that plaque is present, but just the presence of fat content after food has been ingested and absorbed will alter this vasoreactivity, the blood vessels' reactivity. So people can actually now assess in the earliest forms, even using some biochemical markers, those folks who are not having appropriate vasodilatation. Those are the same folks that who are at highest risk for developing stroke, heart attack, and even other manifestations of atherosclerotic disease, including, unfortunately, early death. So looking at vasoreactivity is another